Good morning, everyone. Thank you so much for joining us today. My name is Jo, and I work in the Charitable Activities team here at Ovarian Cancer Action. Today, we're joined by Dr. Jon Krell, Clinical Associate Professor and Consultant Medical Oncologist at Imperial College London. Thank you so much for giving us your time today. Today, we've got a short webinar for you following the fantastic news that Elahere was approved for use in by NICE in England. And just before we start, I'd like to take the chance to say thank you to all of our supporters who shared their experiences with us, because this helped us to tell NICE how important these options are to all of you. And it definitely made a difference to the decision that NICE made. Just to let you know, we will be answering some of the questions that you've sent in at the end of the webinar, but just to note that we're not able to answer any questions about your specific individual medical situation. So please do speak to your own medical team to find out about the options available to you in your specific situation. So without further ado, I'm going to pass over to Dr. Jon Krell now to tell us all about Elahere. Thank you, Jon.
Thank you. Thanks for joining us today. I'm going to talk, as you know, about Elahere. It's recently been approved by NICE. It's been available privately to patients for around about a year following its licensing a year ago. So we have some experience already in the clinics treating patients in the private setting, and just very recently now starting being able to use it in NHS clinics as well. So what does this mean for patients is really the theme of today's webinar. So I'll talk a little bit about what Elahere is, how it works, which patients are eligible for it, what the benefits are in terms of the main trial data from the MIRASOL trial. I'll talk a little bit about side effects and our experience with that in the clinic as well, and how accessible it is to people in England and the rest of the UK as well, because as you probably know, the funding arrangements in England are slightly different to Wales, Ireland and Scotland. And then there'll be time for questions and answers at the end. So what is Elahere? So Elahere is a drug for treating ovarian cancer. It's what we call an antibody-drug conjugate. So what does that mean? That means that the main base of the drug is an antibody that targets a specific protein. And attached to that is a drug via a linker protein. And there are lots of antibody-drug conjugates now being developed or making their way through into the cancer clinic, and they all involve an antibody against a specific protein with a specific drug attached to it. Both the antibodies and the drugs vary, so you can imagine the scope for hundreds, if not thousands, of different antibody-drug conjugates that will come through to the clinic. So what's special about Elahere, or mirvetuximab as it's also known, in terms of ovarian cancer? Well, the antibody targets a protein called the folate receptor alpha. Now, this is a protein that's on all of our normal cells, mainly what we call epithelial cells. So they're cells that line things like the skin or the lining of the bowel or the lining of the ovary. And we know around about 30% of patients who have ovarian cancer, the tumour or the cancer cells will have high expression or high levels of this protein called the folate receptor alpha on the surface of the cells. And the idea is that this drug specifically targets that protein. So when we give the drug through the veins, the antibody gets directed directly to these cells that have high expression of this protein, and they deliver the drug directly to the cancer cells. It's given as an infusion every 3 weeks over around about an hour in total. So who's eligible for the drug? Well, so it's anyone with the type of ovarian cancer called high-grade serous epithelial ovarian cancer who have what we define as a positive folate receptor alpha status. So what does that mean? That means we take a sample of someone's tumour, either from previous surgeries or previous biopsies, or if necessary, from a new surgery or a new biopsy. It goes to the pathology lab, they take a little slice, they put it on a glass slide, and they drop some liquid containing antibodies to the protein that stains for that protein. And a machine then measures how high the levels of that protein are on that sample of tumour tissue. And if it scores 80% or over, then that would be classed as a positive folate receptor alpha status. So what we're doing now, and what we're able to do, is to send samples from patients' tumours off to the lab to test whether they have a high expression of the protein, to see whether they'll be eligible for the drug. Other things that are required for eligibility for the drug are that patients have to no longer be responding to platinum or carboplatin or cisplatin, what we call platinum-resistant disease. Now that has various definitions, and that definition, as you may know, has changed over recent years. That definition used to mean anyone whose cancer had grown whilst receiving platinum, or anyone whose cancer had progressed or grown within 6 months of stopping platinum-based chemotherapy. That latter definition has generally gone out of the window a little bit because we know that there are patients who can still benefit from platinum even if the cancer started to grow 6 months after their last treatment with platinum. And really, it's almost the former definition that patients who don't respond to platinum treatment when it's given, or the cancer progresses very soon, weeks after stopping it. The other eligibility criteria that's very important is in patients who've received more than 3 previous systemic treatments are no longer eligible. So it can be given as a 4th-line treatment, a 3rd-line treatment, a 2nd-line treatment, but it can't be given as a 5th-line treatment. So patients are only allowed to have had up to 3 previous treatments. Put the phone on the hook. So what are the benefits? So why are we giving this drug? We're giving this drug because it's, sorry, one second. So we're giving this drug based on the results of a study called the MIRASOL trial. And that was a trial where we gave mirvetuximab to patients with ovarian cancer that had had 3 or less lines of treatment and whose cancer had progressed or grown within 6 months of receiving a previous line of platinum-based chemotherapy. Some of the patients received mirvetuximab, and the other group of patients received what was considered standard of care chemotherapy. So it was what we call a randomized trial where patients either received the study drug or they received standard of care chemotherapy. It wasn't what we call a placebo trial. No one received a dummy drug. And the results showed a statistically significant benefit in Elahere over chemotherapy in a number of the parameters that they were checking. So the first is what we call progression-free survival. So that means how long the patients benefit from the drug, so from starting the drug to when the cancer might grow over a certain amount. So the average progression-free survival increased from 4 months in the chemotherapy arm to 5.6 months in the Elahere arm. Now, some people might look at that and say, well, that's only 1.6 months. That's not a long time. But 2 things to say there. The first is this is just an average. So there are some patients that would have benefited for months or maybe even years but by receiving Elahere rather than chemotherapy. There will be some who benefited very little or not at all. And so the most important thing there is that this is statistically significant, that we know in this group of patients, Elahere is a better drug overall than standard of care chemotherapy in terms of the length of time that it controls growth of the cancer for. And we see that in the next parameter that was measured, which we call the median overall survival. That's essentially how long people live for following starting the trial. And the difference there, you can see, is nearly 4 months. So interestingly, although the progression-free survival median was only 1.6 months, we see patients living for 4 months longer in the group that received Elahere versus chemotherapy. And I think, again, what does that tell us? That just tells us that these are just numbers, these are averages. They give us an idea as to whether this drug is likely to benefit patients over standard of care. And I tend not to fix too much on those numbers themselves, because I think some people might find them quite underwhelming and not really demonstrate the significant benefits we're seeing of this drug in some people. And I think that's seen just there in the latter point, or the latter 2 points really, is that more people's tumours responded to Elahere compared to chemotherapy. So a significant proportion of patients had what we call the response rate, the number of patients responding, was much higher in the patients who received Elahere over chemotherapy. What does that mean? Well, that generally will mean that their symptoms were better. So people who had symptoms related to the cancer, many more of those had a reduction in the size of the tumours and the cancer on Elahere compared to chemotherapy, and therefore their symptoms would have been a lot better and quality of life would have been better on the drug. And then the final point is that 5%, so 1 in 20 people in the Elahere group, obtained what we call a complete response, where giving the Elahere led to complete resolution of any sign of cancer on the follow-up scans, whereas we didn't see complete responses in any patients in the chemotherapy arm. So I think there were some very positive outputs from the MIRASOL trial that are far more impressive than if we just look at those numbers in those top 2 points. So what are the side effects of Elahere? It's a very different drug to the chemotherapy that a lot of patients are used to taking. That said, it does contain a chemotherapy element to it. It's just that chemotherapy is being directed via the antibody to cells that overexpress the protein. So a very well documented side effect, but I think from my clinical practice, one that probably isn't as significant as we were perhaps led to believe from the initial trials, is that just over half of patients do develop some form of problem with their eyes. So why does that happen? Well, we think it happens because the antibody, and more importantly, that linker that attaches the drug to the antibody, seems to work its way into the tear ducts and gets excreted onto the cornea and the surface of the eye. And it causes a little bit of inflammation of the eye. And that's probably all, or pretty much all, that the drug is doing. And that causes dryness of the eyes. It can cause blurring of the vision. It can cause inflammation to the cornea and sensitivity to light and some eye pain. So patients going on Elahere just have to have an eye check before they start. And then every 6 weeks, every 2 cycles initially, whilst they're on the drug. And usually the treatment is just to take lots of eye drops whilst you're having the treatment. Initially, that's with lubricant type eye drops like hypromelos, just to keep the cornea quite moist. Some patients need steroid eye drops just to help with the inflammation. And if that's done, usually there's no long-term damage at all to the eyes. And these changes are all reversible, either by stopping the drug or almost always giving things like steroid drops. Other side effects, like a lot of chemotherapies, it can cause some diarrhea, it can cause some sickness and some fatigue. Occasionally it can cause some numbness of the hands and the feet, a bit like drugs like paclitaxel. And it can affect the blood counts like chemotherapy. So occasionally it causes a bit of irritation to the liver, and it can cause a reduction in red blood cells, white cells, and platelets. Very rarely, and this is a side effect that's quite specific to these antibody-drug conjugates, very rarely the antibody can get to the lung and cause a sort of immune reaction in the lung that we call pneumonitis. And that would normally present as a cough, a dry cough, some shortness of breath, and on a scan we would see inflammation. And that's almost always treatable by stopping the drug and giving steroids, and that inflammation settles down. The decision we then have to make is, can we restart the drug? And that's always a decision to make between a patient and the doctor, and looking at how severe the pneumonitis might have been and how quickly it resolved with steroids. And the other important point is Elahere, unlike some of the chemotherapy drugs, doesn't cause hair loss. So who can access Elahere now? So through the National Health Service, the most recent NICE decision to allow access to patients with high-grade serous ovarian cancer to Elahere only applies to England initially, but in Wales that follows 60 days after the NICE decision, so we must be around about there now. And I've had communications with some patients in Wales who are just about to access the drug. In Northern Ireland, we don't currently have a time frame for when it may be available because the review and the endorsement hasn't yet been made. And in Scotland, there's currently a review in progress, and we expect them to make a decision hopefully early next year. So how do you access Elahere? Well, through the NHS in England, you can access Elahere now as long as you fit those eligibility criteria we talked about: high-grade serous ovarian cancer, high folate receptor alpha expression, no more than 3 lines of previous chemotherapy, and whatever the definition would be of platinum-resistant disease. If you're not currently eligible or in a different part of the UK, access is a bit more challenging, but that shouldn't be for too long. And I think it's just worth saying there are some clinical trials ongoing or in the pipeline looking at the use of Elahere in slightly different settings, slightly what we call earlier settings. So perhaps giving it as a maintenance therapy after carboplatin, or even with carboplatin or other forms of chemotherapy or targeted treatments. So there will be access to Elahere in other settings. And it's probably also worth saying there are other drugs, similar drugs targeting the same protein in the pipeline as well, which may have slightly different eligibility criteria as well. So that was all the slides I was going to talk about. Sorry about the phone interruption. I'll take any questions.
Thanks so much, John. That's incredibly interesting and really, really helpful explanations there. So we did have a fair few questions come through, and what I've done is I've tried to group them together a little bit into some themes. So first off, you did mention a little bit about the biopsy process, but we did have a question. If you had a biopsy right at the start of your treatment that was able to be tested, would you need a repeat biopsy once you've had a recurrence to find out if that recurrence was also folate alpha positive?
Yeah, it's a very good question, and the reason it's a good question is you don't need to have a new biopsy. So as long as there is tissue from a previous surgery or a previous biopsy, that can be sent for testing. And as long as the protein that we're testing is not degraded, because sometimes proteins over time can degrade. So, you know, if it's 10 years old, the sample, you might still be able to get a result, but it might be that it's degraded a little and we don't get an accurate result. So you can certainly use an old sample for testing. You can use a new sample. There are some people who would say, but it's better to use a new sample because it's more current. It tells us a little more about the biology of the cancer right now when we're thinking about using the drug. So repeating a biopsy is certainly very acceptable, and some people will choose to do it. I think there is always this issue of what we call heterogeneity. So what does heterogeneity mean? That means that there may well be differences between tumours in terms of the expression of the protein. So there may be an area of cancer down in the pelvis and another area of cancer, say, on the surface of the liver. And if we biopsied them separately and looked at the folate receptor expression, we might actually see differences in the expression of the folate receptor alpha from the cancer cells on the surface of the liver versus the cancer cells down in the pelvis. And we've seen this with other ADCs or antibody-drug conjugates. Enhertu in breast cancer is a good example. We used to only see or believe there was a utility or a benefit of Enhertu in breast cancer in patients who had very high expression of HER2, the target for Enhertu. But since then, we've seen patients with very low expression of HER2 still benefiting from the drug. And that probably tells us two things. One, the drugs are probably more specific than we think in terms of being able to target cells, even if there's low expression of the target. And the second thing is that heterogeneity probably plays a part, that when we think there's only high expression or only low expression, there's probably both. And the drug might be more beneficial to patients than we think, even with lower expression. And I think just one more point that I would make from my clinical experience based on that question is that there are patients who have had a test, say on their initial sample, that was negative. So the expression of the folate receptor was less than 80%. And I've repeated a biopsy and it's come on maybe a newer sample or even sometimes a different sample from the initial surgery, and it's come back positive. And as long as we've got a positive result and the patient then meets the other criteria, they're eligible for the drug, even if they've had one negative test and one positive test. And there are 3 patients I look after at the moment who are receiving Elahere and doing very well, where the initial test was negative and the repeat test was positive. And I know that creates some uncertainty, but my advice is if you get a negative test, see if you can get a repeat sample, either on previous test sample or a new one, because it may be that the second one is positive.
Thank you. I think that's really helpful advice for everyone watching. So thank you. Another question we had was if you're on Elahere and have to come off of it, are you then able to have more chemotherapy afterwards?
Absolutely. So there's nothing that says you can't have chemotherapy after Elahere has been stopped for whatever reason it's been stopped, as long as the doctors feel and the patient might feel it's going to be beneficial, and there's good options there. So certainly, I think one of the points to that question is, well, where might we use it? If I'm on second line treatment and I'm eligible for Elahere, should I have it then, or should I maybe wait till the third line? And I would think of this as an additional drug rather than as an alternative to chemotherapy. We can give chemotherapy after Elahere.
Okay, thank you. And a question that might link in a little bit with that actually is whether you can tell us why this and other similar drugs aren't available as a first stage treatment, but only after recurrence when you've perhaps already had damage from chemotherapy.
Sure. So one day they might be. In ovarian cancer, because a significant proportion of ovarian tumours are very sensitive and responsive to carboplatin, it's very difficult to consider other drugs as being likely to be more beneficial than carboplatin. So a lot of new drugs are tested in the same setting that Elahere was. They start in the sort of platinum resistant setting in patients who've had a few lines of treatment of platinum. And we see whether there's a signal for benefit for those drugs. And if there is, we then tend to see trials working their way up to the second line and even the first line setting. And we saw that with PARP inhibitors. The initial PARP inhibitor trials were done in the recurrent maintenance settings, and they then made their way up to the first line setting. I think just on that point, we know that probably around half of ovarian cancers are not as sensitive to platinum as others. They're the group of ovarian tumours that we call homologous recombination proficient. And I think, again, and I hope that we're moving towards a treatment pathway where those patients who we think are likely to respond less well to platinum in the first line setting, we're starting to do more testing of the tumour and developing newer drugs to target the proteins and the molecules in those harder to treat ovarian cancers that make them different to the platinum sensitive type of homologous recombination deficient tumours. So I think Elahere will work its way up into the second, first line setting even, particularly for those patients who have that harder to treat type of high-grade serous ovarian cancer.
And kind of the opposite end of the spectrum, we had quite a few questions about the idea of not being able to have Elahere after third line of treatment. So I don't know whether you have anything that you can tell anybody watching about options in that situation, whether it's likely that Elahere will be available or similar drugs might be available for people who've had more lines of treatment.
Yeah, so Elahere won't be available, unfortunately, to patients who don't fit that strict criteria. And, that is in the NHS based on the NICE and the Cancer Drugs Fund approval for Elahere, but also even privately, the license for Elahere is in that group that have had 3 or less lines of treatment. So it's very difficult to get Elahere for patients, even if they're folate receptor alpha positive and platinum resistant, if they've had 4 or more lines of treatment. That said, there are other drugs coming through the pipeline that aren't necessarily chemotherapy. Enhertu was an example that I spoke about earlier in breast cancer. That's an antibody-drug conjugate against a protein called HER2. And there was a trial called the Destiny PAN-02 trial, which reported a couple of years ago, which was testing Enhertu in lots of different cancers, including ovarian cancer. And as of around April last year, Enhertu has been licensed for use in HER2-positive ovarian cancer, but it isn't yet approved or funded by NICE. So that's just one example of another ADC that's just a bit behind Elahere, but I think eventually will become available. And there are other drugs coming through that pipeline as well. And of course, there are also clinical trials which give access to more targeted, more novel therapies.
Thank you. And we've probably got time for another one. We did have quite a lot of questions about other subtypes of ovarian cancer, specifically low grade. And so whether you can tell us whether you know of any trials or drugs coming through for this particular type of ovarian cancer or other subtypes of ovarian cancer.
Yeah, so I mean, certainly one thing we're learning is that all the different subtypes of ovarian cancer on a molecular level, on a biological level, are quite different to each other. So low-grade serous ovarian cancer, very different to high-grade serous ovarian cancer, biologically or molecularly. So that means when we look at different proteins that may have gone wrong or changed or maybe driving the growth of the cancer cells, they're very different to the ones we see in high-grade serous ovarian cancer. And there's one pathway in particular in low-grade called the RAS-RAF-MEK pathway. And this is like a cascade of proteins that may be overactivated in those cells that stimulate the growth of those cells. And there are drugs like trametinib, cobimetinib, and various others that have been developed and have been through trials that are shown to inhibit or slow down the stimulation of growth of cancer cells through that pathway. And trametinib is one that's available. Cobimetinib is becoming more available. And there are a number of others. There are some that target a protein called FAK, as well as MEK and others. So definitely there is progress being made in understanding the biology of these other subsets of ovarian cancer and developing drugs to target those proteins. And some of them are making their way into the clinic. And certainly there are clinical trials of these drugs available to some patients as well.
Thank you so much. And thank you for answering all of those questions. I'm sure if anybody has any further questions, they can get in touch with us and we will try and get them answered. We'll be wrapping up now. Thank you so much, Dr. Jon Krell, for giving us your time today. It's much appreciated and we know how busy you are. So just so everyone knows, the recording of this webinar will be sent around to everybody who's registered. And if you need any more information or would like to find out any more information about Ovarian Cancer Action, please head to our website, which is ovarian.org.uk, or get in touch with us. Thanks again, John. We really, really appreciate your time, and thanks everybody for watching. Have a lovely day.